Subscribe now and press the bell icon. Never miss an update.
Welcome you all to today's interactive session on Vermiform appendix and its diseases. So this is the Vermiform appendix. The diseases of the Vermiform appendix are. So before starting the diseases, we first recapitulate the anatomy of the Vermiform appendix. It is a blind-ended tubular diverticulum which arises from the posterior medial wall of the cecum about 2 cm below the ileocecal junction. So look, this is the ileocecal junction. So that appendix lies 2 cm below and posterior medial wall of the cecum. And the average length is 7.5 to 10 cm. The length of the appendix is usually 7.5 to 10 cm. Usually, it may be a long more, it may be a short, below the 7.5 maybe. But average there is 7.5 to 10 cm in length. It is suspended by a peritoneal fold, which is called the mesoappendix. So look the picture. There is a peritoneal fold attached with the appendix. That fold is called the mesentery of the appendix, called the mesoappendix. Specific name is mesoappendix. The breadth of mesoappendix falls short of the length. The breadth is short than comparison to the length. The body of the appendix is kinked on itself where free border of the mesoappendix ends. Hence, it is coiled like worm and is named the vermiform. That means the body of the appendix is kinked on itself. If the appendix is more length, so the mesentery is short, so the appendix becomes kinked. For that reason, the body of the appendix is kinked on itself, where free border of the mesoappendix ends, and hence it is called coiled like worm and is named the vermiform. It is devoid of tinea coli. That means, in comparison with the cecum, the longitudinal muscle is arranged a 3 band-like muscle fiber there. So, 3, which is called the tinea coli. But in case of appendix, there is no tinea. The longitudinal muscle is completely circumference coverage of the appendix. So this is the difference between the cecum and the appendix. For that reason, it is written, it is devoid of tinea coli, circulations, and appendices irregularly. So this is the cecum and ascending colon. The longitudinal muscle is there, and surroundings there is a circular muscles. So that arrangement causing some circulation of the large guard of the intestine. For that reason, the appendix, there is no circulation and no appendiceal plaque is there. All the tinea of the cecum converge to the base of the appendix, which serves as a guide for the identification of the appendix. This is very important line because where you search or starting the searching for appendix, so our aim to identify the cecum, go to the base of the cecum where the tinea started. And where the tinea started, here the appendix basis lies. So this is the anatomical landmark which dictates and easily can identify the appendix during appendicectomy. The cecal opening is guarded by an incomplete mucus fold, which is called bulb of Galles. if you look inside the endoscopic view, there is mucosal fold there. So this is called the bulb of Gurlitt's. Appendix is supplied by appendicular artery. So the appendix is supplied by an artery, which is appendicular artery. That appendicular artery is a continuation of the ileocolic artery. And this appendicular artery is run through the free margin of the mesoappendix. During running, they give some branches. That branch can supply the appendix. And near the appendix tip, the artery enters inside the muscles. So this is the anatomy and the distribution pattern of appendicular artery. So appendix is supplied by appendicular artery, branch of ileocolic artery, which is an end artery. Appendicular artery passes behind the terminal ileum. Look, passes behind the terminal ileum to enter the mesoappendix, a short distance from the base of the appendix. It is a short distance from the base of the appendix. It is not too close to the base, short distance. It then comes to lie in the free border of the mesoappendix, but for a variable distance from the tip, where the mesoappendix is lacking, the artery lies directly on the muscle wall beneath the peritoneal cord. And the tip of the appendix is least vascular. The tip of the appendix is least vascular. So, as tip is least vascular, in obstruction of the artery, gangrenous change is observed at the tip. Position of the Vermiform appendix. It is very important because frequently asked in the exam, what are the percentage of the normal anatomical position of the appendix are. So that percentage are given by the autopsy result, autopsy findings of the patient, autopsy findings of the individual. From that, they can evaluate, and the percentage is written in the books. So look, their first position is called the retrocecal appendix, which is about 74%. Retrocecal, that means the appendix lies behind the cecum. So this dotted represented it behind the cecum. So why that retrocecal position is common? Why? The anatomical explanation is, it is an embryological representation because whenever the intestine is developed, during that time there is the gut is protruded out through the umbilicus, again go in, so reduction is completed, and ultimately it settled in the right hypochondrium, and later on it migrated to the right iliac fossa. So during development, the cecum first placed at the right hypochondrium in the upper part. So whenever the cecum is there, so the tip is hanging there. But subsequently, when the child grows, the body increases in size, the cecum is descend down. So that descend down, causing the tip is there, the base is lies there. For that reason, that lengthening of the ascending colon, causing the appendix is retrocecal position. For that reason, the retrocecal position is 74%, is highest in percentage. The other varieties are, pelvic variety is 21%, pre-ileal is 1%, post-ileal is 0.5%, paracecal is 2%, subcecal is 1.5%. So look at the picture. The terminology of the appendix position are made by the location of the appendix. So if the appendix lies behind the cecum, it is called the retrocecal. If the cecum lies in front of the ileum, so it is called the pre-ileal variety. If the appendix lies behind the ileum, it is called the post-ileal variety. If the appendix is hanging and go down into the pelvic cavity, then it is called the pelvic variety. And some appendix may lie just attach the lateral border of the cecum, which is called the pericecum. And some are appendix lies not pelvic, not the pericecal, to some extent into the iliac fossa directly there, which is called the subcecal imperative. So these are about the various percentage of the anatomical position of the appendix. That position takes part an important role to locate the presentation of the patient, to locate the appendicular abscess location of the patient. That can depends upon the anatomical position of the appendix. For that reason, the importance of appendix position everybody must know, and you must sincerely and recapitulate your anatomical knowledge from the picture. Another important thing, the line is written in the yellow mark. It is not needed for the undergraduate student, but it is needed for your conceptual clearance. The terminology is retrocecal and retroperitoneal. Look the position, look the cecum. So that cecum is completely covered by the peritoneum. And behind, then the peritoneal reflection go and form the parietal wall peritoneum. So between the parietal peritoneum and the cecal peritoneum, when the appendix lies, it is called the retrocecal imperative. But if the appendix lies behind the parietal peritoneum, it must be behind the cecal peritoneum and also behind the parietal peritoneum, then it is called the retrocecal and retroperitoneal variety. So it is one of the rarest variety of appendix position. So that thing is written in Schwartz surgery book. It is not needed for undergraduate student. Because whenever you search for appendix during appendicitis, you look there, the cecum is pull up, there is no appendix there. In the pelvis, no. So in that cases, if you don't elevate the parietal peritoneum from posterior wall, you don't isolate the appendix. For that reason, that position you also know. So that term retrocecal and retroperitoneal position never ever altered in undergraduate examination. Never ever. So what are the diseases? So the diseases mainly inflammatory and others is neoplastic. So inflammatory again having some varieties. That means it depends upon the inflammatory condition severity. So the terminology are, the disease name is appendicitis, appendicular mass, appendicular abscess, and neoplasms of the appendix. And less common pathological conditions are mucosal of the appendix, diverticular of the appendix, and intersuccession of the appendix, which is intersuccession is retrograde. Intersuccession is a very rare example of intersuccession. Retrograde is appendicocecal intersuccession. And another retrograde intersuccession example is jejunogastric intersuccession in case of gastrojejunostomy, after gastrojejunostomy, through the gastrojejuno stoma. So these two examples of retrograde intersuccession. All other intersuccessions are antegrade, only two. One is appendix, another one is jejunogastric intersuccession. So look the picture. So the appendix is inflamed there, so it is appendicitis, acute appendicitis. The tip is gangrenous, so it is gangrenous appendicitis. And the appendix is distended, probably it is a mucosal of the appendix, maybe, or there is a fecolit in the tip of the appendix, and this is the lump formation in the appendix. So look, this is the retrocecal position of the appendix. What is congenital abnormalities of the appendix? The commonest one is agenesis. if the appendix is not developed since birth, it is called agenesis. And if it is intersuccession of the appendix go to the inside the cecum, so when the appendix is migrated up, so at the folding area of the cecum, there is ischemia. And ultimately, the cecum become gangrenous and the cecum is divided, division, and the appendix is migrated through the colon, go to the exterior through the stool. And in that cases, you also never ever seen there is appendix, no appendix is there. So one is congenital agenesis, another absent probably if it is a retrocystal appendix, retrograde intersuccession is happened. Subsequently, there is auto treatment of the patient is auto appendicectomy, which divided automatically by ischemic necrosis and slapped from the base and passes through the stool, go to the exterior. In that cases, you also don't see the appendix in position. And some are duplication, that means double appendix. During development, there is two appendices there. During appendicitis, you remove the one appendix and go out. If don't examine very carefully, in that case, you can miss another appendix there. Subsequently, the patient having again appendicitis after doing appendicectomy. So in that cases, for that reason, whenever you go for the appendicitis, appendicectomy, so search very carefully, is there any duplication of the appendix or not? So in some instances, one of the twin appendices has been acutely inflamed and the other is uninvolved. So in that cases, also you must remove the normal appendix also. Otherwise, you can misdiagnose subsequently. So another one is the normal cecum is rotated and fixed at the right hypochondrium and ultimately descend down. So location of the appendix is the right iliac fossa. But whenever there is a malrotation of the guard, so the cecum is not in the right hypochondrial fixation. If it is non-rotated or if it is a malrotated, in that case, this cecum and appendix lies on the left side, left upper abdomen. So which is associated with situs inversus. If it is a non-rotated, in that case, the cecum may found in the midline in the very high in position. So in situs inversus, that means heart, lung, everything is reverse. The liver also reverse. And in that case, the appendix is also in the left iliac fossa. For that reason, in situs inversus viscerum, a left-sided appendix is found. It is found in most cases of malrotation of the midgut. So these are congenital abnormalities. So we discuss about the appendicitis. So there are two varieties of acute appendicitis and recurrent appendicitis. In older books, they are having written various types, acute, subacute, and chronic appendicitis. In very old edition of books, some books are written there, but in a new edition, only there is one, acute appendicitis and recurrent appendicitis. So that acute appendicitis have been two varieties. One is acute non-obstructive appendicitis, which is called a catarrhal appendicitis. And another one is acute obstructive appendicitis. Whenever the lumen is obstructed and causing inflammation, infection, then it is called the acute obstructive appendicitis. And others are recurrent appendicitis. That recurrent means the patient having an appendicitis, if he or she treated or non-treated or maltreated, which is resolved, and after a few days there is again some symptom of the appendicitis, again there is symptom-free, then again after a few days or few months the patient presented with some symptoms of appendicitis. This is called the recurrent appendicitis. But in acute non-obstructive appendicitis, there is catarrhal appendicitis. In that cases, there is a less amount of inflammation there, and most of the appendicitis is resolved spontaneously with treatment of physician or by treatment some other medication like Hamdard, Huzur's waters. Then that water can take with the belief that water can cure the disease, but no, there is spontaneous resolution to some extent. Mild attack of appendicitis can resolve spontaneously. So what about the acute appendicitis? The etiologies are no unifying hypothesis. Decreased dietary fiber and increased consumption of refined carbohydrate. So both of them causing constipation of the individual. So that constipation causing the fecal matter become harder in consistency. So that harder consistency fecal matter may enters into the base of the appendix. When passes through the cecum to the ascending colon, then some fecal matter may enters there, and which causing block the base of the appendix. So obstruction of the lumen of the appendix, which is called the fecolith, sometimes referred to as appendicolith. This is composed of inspissated fecal material with calcium phosphates, bacteria, epithelial debris, and rarely a foreign body. That other obstruction of lumen cause is tumor. Suppose a patient having a malignancy arises from the epithelial cell of the cecum base. So if the cecum, there is a carcinoma cecum, so that cecum malignancy, epithelial proliferations, metastasis, mitosis, that means there is a metaplasia, and ultimately not metaplasia, that means when there is a abnormal proliferation with a malignant changes of the epithelium, which is called the carcinoma cecum, and that carcinoma, it blocks the lumen of the appendix. So that blocking causing the luminal content is stay there, mucus is secretion there, so there is distension of the appendix, and the patient may present it as a acute appendicitis. So all the time, the acute appendicitis are not a benign disease. To some extent, sometimes it may present it as a malignant disease presentations. The presentation of the appendicitis is not due to the obstruction, not only the benign cause, it may be a malignant cause lying there, particularly in case of elderly individual. Whenever an elderly individual present to you as an acute appendicitis, always cautious about the patient may having associated with carcinoma cecum, maybe. And carcinoma cecum diagnosis is usually lately because the caliber is wide, there is less obstructive symptoms, and there is a more slowly release loss of blood. The patient presented as an unexplained anemia. So whenever an elderly patient unexplained anemia along with appendicitis, be careful about it. The patient may having a carcinoma cecum there. So rule out the malignancy first, then immediately go for surgery. If there is no malignancy, then the treatment is immediately go for appendicectomy. If the patient having a malignancy, you must treat the malignancy simultaneously. Otherwise, the patient are not cured from the disease. And another one is rarely sometimes we see whenever we divide the appendix, some worm is came out from the base of the appendix. So that pinworm is a ball of pinworm enters inside the lumen and block the lumen and may present it as acute appendicitis because it's due to the worm enters inside the lumen of the base. So intestinal parasites. Oxyris vermicularis, known as pinworm. And another one is lymphoid hyperplasia. It is also a very important term is lymphoid hyperplasia. The appendix is a very rich of lymphoid tissue. Whenever the patient having a viral infection, so that viral infection causing generalized lymphatic hyperplasia. So that lymphatic hyperplasia at the base of the appendix may swollen there, it may block the appendix and may present it as acute appendicitis along with the viral diseases. So that thing, examine the patient may sometimes present to you with a tonsillitis, their tonsil is enlarged there is infection there, the patient may present with along with generalized lymphadenitis. So any other cause of lymphatic hyperplasia, generalized presentation, that also may affect the base of the appendix and causing hyperplasia, occlusion of the lumen, and presented as a acute appendicitis. So be careful about the etiology of appendicitis. So what about the pathophysiology of appendicitis? That means whenever the lumen is obstruction of the appendicular lumen, appendiceal lumen, then continued secretion of mucus because there is lining epithelium there, and there is inflammation there, so inflammatory exudate is accommodated within the lumen. So increase interluminal pressure, and also that pressure causing even upon the wall, and also cause obstruction of the lymphatic drainage. So the interluminal pressure causing the pressure effect over the wall. So over the wall there is the lymphatics. So obstruction of the lymphatic drainage, edema, mucosal ulceration develops with bacteria. Whenever the edema and mucosal ulceration develops, in that time there is a translocation of bacteria from the lumen to the circulation. Bacterial translocation to the submucosa, and resolution may occur at this point either spontaneously or in response to antibiotic therapy. So because mucosal ulceration, if you prescribe some antibiotics or spontaneous may resolve if you don't progress further. If the condition progresses, further distension of the appendix and causes venous obstruction and ischemia of the appendix. With ischemia, bacterial invasion occurs through the muscularis propria and submucosa and represented as acute appendicitis. And ischemic necrosis of the appendix wall produces gangrenous appendicitis, ultimately perforation. So alternatively, the greater omentum and loops of small intestine becomes adherent to the inflamed appendix, walling of the spread of peritoneal contamination and resulting in appendicular mass or paracecal abscess. So be careful about it. Whenever the inflammations affected the surface of the appendix, then the body defense attitude, they localize the infection. So that localization is made by some policemen. The policemen are greater omentum. So when the greater omentum migrated there and make a adhesion along with the appendix, in that time the surrounding structures like terminal ileum, cecum, and sometimes the sigmoid colon, or in case of female, sometimes ovary, fallopian tube, all take share to localize more blood supply there, wash out the infection from the side, that causing a lump formation, which is called the appendicular mass. If the infection is not resolved by washing the area with the surrounding viscerous blood vessels supply there, in that cases, the infection is multiplied there and ultimately it forms into the abscess formation. So rarely appendiceal infection resolves and leaving behind distended mucosa, mucus-filled organ, and represented as a mucocele of the appendix. So mucocele of the gallbladder and mucocele of the appendix, there are two terminology. The mucocele of the appendix also occurred in the appendix. Mucocele of the gallbladder also developed in case of gallbladder disease. So mucocele in the two area. Always remember, because sometimes ask in the exam, whenever you say it is mucocele of the gallbladder, then some question asks, tell me another mucocele, which organ affect? Then your answer it is mucocele of the appendix. So risk factors for perforation of the appendix. Perforation of the appendix. So risk factors are there. So extremes of ages. These two things is very important thing is extremes of ages. That means one is too early age, that means in case of children, and another one is too extreme age. Another extreme age is the elderly individual. So that both the ages risk of perforation. Because in case of older, younger age groups, in case of children, there is omentum is short. So if the omentum is smaller in size, it does not capable to migrate there and take part share for lump formation or resolution help. For that reason, there is chance of perforation. In case of elderly, there is a lack blood supply. So that issue is more vulnerable to take part share there. In that cases, more atherosclerotic blood vessels there is more chance of perforations. Immunosuppression age groups, there is a vulnerable to, if there is any suspicion of appendicitis, you must remove it. Otherwise, there is a chance of burst appendicitis occur. And diabetes mellitus, those individuals having diabetes mellitus, if any suspicions, you must remove the appendix. Otherwise, may late complications, so many complications may develop. And fecal obstructions. Do a plain X-ray that there is a fecal shadow there. If there is a symptom, or if not a symptom there, if the individual is very important one, like he works very important job done, so in that cases, his work time is very important. So if there is a fecal shadow there, confirm it by doing a CT scan. Is it within the appendix or not? If within the fecal, within the appendix, by confirming with the CT scan, then you must remove prophylactic appendix. Otherwise, at any time, any complication may develop. So pelvic appendix is also a very important one, because the pelvic appendix, whenever they are the patient having presentations are not mimic with typical presentation of appendicitis. There are some atypical presentations because the appendix lies inside the pelvic cavity. Whenever it is inflamed, organ irritate the rectum, so there is a loose motions there. So that loose motion may presented as a viral diarrhea, other diarrhea, etc. mislead you. For that reason, pelvic appendicitis, pelvic appendix position is very dangerous for diagnosis and treatment. And previous abdominal surgery. So if the patient has previous abdominal surgery there is an adhesion there, so the appendix position may king and may causing appendicitis there. For that reasons, these are the risk factors for perforation of the appendix. Clinical features. The symptoms and signs. Symptoms means the patient presentations. The patient, those dialogue given to you, these problems happen. So this is my problem. So you will know what are the problems are. That means where the pain is. Initially, the pain is around the umbilicus. The patient present to you, I feel pain around the umbilicus or sometimes in the epigastrium, and then gradually shift to the right lower abdomen. So initially pain around the umbilicus, then shifted to the right iliac fossa. And another one is anorexia, and there is nausea and vomiting. That nausea and vomiting presentations is due to the body defense attitude. Whenever any pain in the abdomen, so if you take more ingestion of food, the stomach is distended, there is more peristalsis there, more work needed, so that movement causing more feeling of pain. For that reasons, body defensive attitude, reflex spasm at the pylorus whenever any pain in the abdomen. So reflex spasm causing some back flow of content of the stomach, which presented as a nausea and vomiting. So that pain around the umbilicus and shifted to the right iliac fossa. That two things must know, because the pain around the umbilicus, that represented that the pain is not lesion, don't lies in the umbilicus. The lesion in the viscera. The visceral pain we don't able to feel from the outside. Until and unless it can irritate the parietal peritoneum, or in fact irritate the parietal peritoneum, then your presentation that there is a feeling of pain, because the gut having no pain sensation. So the same innervation of the midgut, the midgut derivatives pain is represented around the umbilicus. For that reason, the appendix is a midgut organ. For that reason, the pain, inflammation in the appendix, initially distension, causing feeling of pain, that pain is around the umbilicus. But whenever the infection and inflammation is proceed forwards, then more inflammation there, then the appendix touches the parietal peritoneum, then the feel, for that reason the pain is shifted to the right iliac fossa. So first pain around the umbilicus, then shifted to the right iliac fossa. And if you examine, the patient having a pyrexia. So the pyrexia 37.2 to 37.7 degrees Celsius. Not too much more marked of pyrexia, because if there is abscess formation, in that case high rise of temperature. Otherwise, not more marked of pyrexia there. Then localized tenderness in the right iliac fossa with maximum tenderness in the McBurney's point. So you must know where the McBurney's point lies. You must know. Otherwise, you don't able to diagnose that the highest point of tenderness where it is. So localized tenderness in the right iliac fossa with maximum tenderness in the McBurney's point. And whenever the parietal peritoneum is inflamed, then the patient presented with a muscle guarding. When more parietal peritoneum, more inflammation, then muscle guarding. But whenever the patient having a pain there, if you make a pressure at the right iliac fossa, go gradually deepening the pressure, deepening your hand, giving more pressure, and suddenly you release your hand. So whenever you release your hand, the muscle moves more. Parietal peritoneum also moves. At that time, the patient feels more pain. The pain is not during pressure given. The pain is occurring whenever you release your hand, movement of the muscles of parietal peritoneum. At that time, the patient feels pain, which is called the rebound tenderness. Typically, acute obstructive appendicitis has more acute course than acute non-obstructive appendicitis. And the onset of the symptom is abrupt. Be careful about it. Whenever a fecolite enters inside the base of the appendix, so suddenly they enters, whenever that more pressure enters, passes the more constricted part, at that time the patient feels pain. For that reason, it is called onset of the symptom is abrupt. And there may be generalized abdominal pain for the start. The temperature may be normal and vomiting is common. So the clinical picture may mimic with acute intestinal obstructions. So be careful about it. For that reason, it takes time to diagnose acute appendicitis. Don't hurry. The signs to elicit, pointing sign. You ask the patient, in case of particular children, if you take the history of the patient and ask very carefully, elaborately, where you first feel the pain, and what about the location of the pain now? So, show me where the pain it is. Then, in a good intelligent patient, he directly can point at your site of pain. For that is a pointing sign. Patient is asked to point where the pain began and where it moved. Robson sign, it is a very important thing is, if your inflamed organ moves from a remote area and the patient feels pain at the site of the location of the organ, it is more confirmatory, because if you place your hand on the right side, that pain may be a false one. If you place your hand on the left side, left iliac fossa, and make a pressure, and all the viscera is migrated on the right side, so the pressure if it given over the right iliac fossa content, so there is a movement of the appendix and parietal peritoneum. If the patient feels pain on the right iliac fossa, moves, press there and feeling of pain here, opposite side, it is called the Robson sign. Even deep palpation in the left iliac fossa may cause pain in the right iliac fossa. So this is called the Robson sign. It is more confirmatory one. More confirmatory, it is Robson sign. One is point tender, another one is Robson sign. There is other signs there, which is called the Swas sign, or another name is Kopp-Swas sign, or the Kopp-Swas test, and there is a Kopp's obturator test. That Kopp-Swas sign and Kopp's obturator test sign are, these two signs dictate you what is the position of the appendices. You memorize the first slide, say, of position of the appendix. If it is a retrocecal in position, so the cecum lies in front of the psoas major muscles. So, retrocecal position of the appendix is located just behind the cecum, that means in front of the psoas major muscle. So in front of the psoas major muscle, there is a fascia, psoas fascia. So if you examine the psoas major muscle extension, so whenever the psoas muscle the muscle is moved due to the extension of the hip, so that causing inflamed appendix attached to the psoas fascia, the patient feels pain. It is called the psoas sign. Cobb's psoas test. Occasionally, an inflamed appendix lies in the psoas muscle, and the patient lies in the right hip flexed of pain relief. If it is extended, then the feels of pain. The feeling of pain during the extension of the hip joint on lying posture on lateral position then indicates that the patient, most likely the appendicular position is retrocecal in position. For that reason, inflamed appendix touches the psoas major muscles and causing inflammation there. Another one is Cobb's obturator test. So where the obturator muscle lies? Obturator muscle lies in the pelvic wall. That means in the pelvic cavity, there is the obturator internus inside. In the outside, there is obturator externus. So if it is a pelvic variety of the appendicitis, if the appendix is hanging in the pelvic cavity on the right side, it touches the obturator fascia. So if you move the obturator muscle, the obturator fascia also moves. So that causing there is a field pain on the pelvic cavity. That is called the Cobb's obturator test. That means if the knee is flexed, hip is flexed, and internal rotation of the thigh, so if you internal rotate the thigh, then causing rotation of the muscles and causing spasm of the muscles and feel pain in the hypogastria. So these are the signs of appendicitis. So McBurney's point. That McBurney's point location is a static one point is the line. There is a line which is called the spino-umbilical line. That means spino-umbilical line. There is the umbilicus, there is the spine. The spine is anterior superior iliac spine. So if you draw a line from the anterior superior spine to the umbilicus and divide the line into three parts. So the point which lies between the medial 2/3 and lateral 1/3. Medial 2/3 and lateral 1/3 of the point junction, the medial 2/3 and lateral 1/3, the point is called the McBurney's point. If you make a pressure there and feels pain, that means that area usually lies the base of the appendix. It touches the base and the patient feels pain, and it is called the McBurney's point tender. So for your easy memorization, we remember it is medial 1/3 and medial 2/3 and lateral 1/3. This is lateral 2/3 here and medial 1/3. So another thing is, if you know the middle third and lateral third, it's very easy to remember. Middle third, the junction between the middle third and lateral third of the spino-umbilical line. But for your exam, your answer is 1/3 and 2/3, because everybody are memorized like that terminology. But easy remember, it is middle third and lateral third junction. So in that case, there is no confusion. But in the book written, everybody's are remembered by like this 2/3 and 1/3. But my presentation is, my liking is middle third and lateral third junction of the spino-umbilical line. So another important thing in the long case sometimes ask, how can you identify the anterior superior iliac spine? Show me the anterior superior iliac spine. So most of the student can go for a mistake because they are palpate the inguinal ligament, go laterally. No. In that cases, you just place your hand over the iliac crest, then you come forward. And where the pointed end lies, this is the anterior superior iliac spine. This is the anterior superior iliac spine. Sometimes in the long case, that type of question sometimes asks, show me the anterior superior iliac spine. Show me the pubic tubercle. So how can you examine the points? You must read from the book S dash. So this point corresponds with the base of the appendix, which is attached to the cecum. The maximum tenderness is felt at this point in case of acute appendicitis. So there is a triangle, sometimes asked in the exam, what is Sherrin's triangle? That means it is an area of hyperesthesia found in acute appendicitis. That means it is bounded by the line joining the anterior superior spine, pubic tubercle, and the appendix. So it is a triangle. If you draw that area, if there is hyperesthesia, that means it indicates there is some inflammation is there. So it is a plus point that the hyperesthesia is a positive findings for favor of appendicitis, which is called the Sherrin's triangle. Special features based on appendix location. So look, retrocecal appendix. The rigidity is often absent. Be careful to know and more concentrate the subsequent few lines, because this is the very important parts. If your conception, if you're clear, you can easily diagnose in earlier presentations the patient may having appendicitis because the location is not the typical one. So for that reason, atypical presentations you must memorize. So retrocecal appendix rigidity is often absent, and even application of deep pressure may fail to elicit tenderness. Silent appendix. The reason being that the cecum is distended with gas. Due to the underlying appendix, there is inflammation. So there is a localized ileus. So cecum is distended there and prevents the pressure exerted by the hand from reaching the inflamed structure. And deep tenderness often present in the loin. So retrocecal appendix diagnosis is very difficult. Another one is pelvic appendix. Occasionally, early diarrhea results from an inflamed appendix being in contact with the rectum. Complete absence of abdominal rigidity and lacking tenderness over the McBurney's point, as the appendix lies entirely within the pelvis. Deep tenderness just above on and to the right of the symphysis pubis, and in that case may be failed or elicited. On digital rectal examination, it is an important rule. So without digital rectal examination, an abdominal examination is never ever complete. For that reason. So if we do a digital rectal examination, then can easily elicit that there is a tenderness on the right side of the pelvic wall. Tenderness is the rectovesical or rectovaginal Douglas pouch, especially on the right side. This is also can give a clue the patient may having an appendicitis, which is the pelvic variety. Spasm of pterygoinal muscle, so pain, the movement of the hip rotation may feel pain there. Contact with the bladder, that inflamed bladder appendix, whenever touches the bladder, so irritate the bladder, there is increased frequency of micturition. Another one is post-ileal appendix. So post-ileal appendix, the appendix lies behind the ileum. So in that case, inflamed appendix irritate the ileum. So that irritation causing increased frequency of the motion. So the inflamed appendix lies behind the terminal ileum. Greatest difficulty because pain may not shift. Diarrhea is a feature and marked retching may occur. Tenderness, if any, ill-defined, although may be present immediately to the right of the umbilicus. It is more medially that tenderness may elicit. So these three important findings of the physician must know. So differential diagnosis of acute appendicitis, there are a lot of written in the books. Only I can utter the names: gastroenteritis, in case of children, mesenteric adenitis, Makes diverticulitis, intersuccession, heinous scalar purpura, lobar pneumonia, and adult regional enteritis, uretary colic, perforated peptic ulcer, torsion of the testis, pancreatitis, rectus edematoma. This torsion of the testis you must remember. It is a very important thing. Lot of consultants can misdiagnose because we are more oriented towards the abdomen. We are not oriented with the genitalia. Because whenever a male patient presents to you right iliac pain or pain in the abdomen or in the lump of the abdomen, always examine the scrotum. Otherwise, you can miss it. Initial pain, whenever the torsion of the testis, the pain is at the root of the vessels. That means the root lies in the testicular vessel lies in the lateral wall of the aorta. So the pain felt in the nerves are there, pulling effect there. So the pain is felt in the abdomen. So initially the patient may not present with the pain in the scrotum. Initially the pain may in the abdominal pain. So right-sided pain or left-sided pain in the male patient, always examine the testis. Always examine the testis. Otherwise you can miss the diagnosis. In adult male, Mittler's March, it is a syndrome, pelvic inflammatory disease, pyelonephritis, ectopic pregnancy, torsion or rupture of the ovarian cyst, endometriosis. So these are all related with the female. That means ovulatory rupture, corpuscular hemorrhagic cyst, there is a bleeding, so there is a pain. And pelvic inflammatory disease, there is a pain. Pyelonephritis, pain. Ectopic pregnancy, the tube of the fallopian tube becomes distended. So initially the pain is there, and whenever rupture, the blood is coming down to the peritoneal cavity, generalized peritonitis is there. Torsion also same, there is a pain, endometriosis. In case of elderly, diverticulitis, particularly in the Western country, always thinking that the patient may be associated with appendicitis, with diverticulitis, or only the diverticulitis which mimics with appendicitis. If the diverticula lies in the cecum, so there is chance of obstruction of the diverticula with the fecal matter, inflammation of the diverticula, and presented as a diverticulitis, and which localize the pain into the right iliac fossa and diagnose it is appendicitis clinically. And after during surgery, you can evaluate that it is not appendicitis. There is a diverticula which is inflamed, distended. This is the cause of pain in the right iliac fossa. So that diverticulitis can exclude it. If you do a CT scan, then you can diagnose there is some diverticula is there. Inflammation of the diverticula may be diagnosed by doing a CT scan. But in our practice, we are not routinely do a CT scan. We are routinely do an ultrasonography. But in a Western country, always before going for appendicectomy, they are more oriented with the contrast enhanced CT scan. Without contrast enhanced CT scan, usually they don't go for surgical treatment of appendicitis. Intestinal obstructions. In case of intestinal obstruction, they can present looks like appendicitis, colonic carcinoma, that means carcinoma of the cecum, torsion of the appendix oblique, sometimes pain there, mesenteric infarction, so midgut pain there, and leaking aortic aneurysm. So these are the differential diagnosis of acute appendicitis. So investigation. The diagnosis of acute appendicitis is essentially clinical. Look, the line written here. The diagnosis of acute appendicitis is essentially clinical. However, decision to operate based on clinical suspicion only can lead to the removal of a normal appendix. You can clinical diagnose appendicitis, so after doing operation, the appendix may be normal. So the diagnosis of acute appendicitis is essentially clinical. Following investigation can be done for more accuracy. To exclude your differential diagnosis, more confirmatory of diagnosis, you need to do some investigation. The investigations are full blood count. That means whenever there is inflammation, the body responds to protect the inflammation by killing the organism needed to more soldier That means more production of neutrophil. So neutrophil is a WBC count. So WBC count is increased, and among them acute infection, for that reason the neutrophil count is increased, which is called neutrophilic leukocytosis. That it is one of the favorite point that the patient having a acute infection there. It is proved. And also do an urine analysis. So that urine analysis can also exclude the patient does not having any sorts of urinary tract infection. That urinary tract infection also pain to some extent on the right or left or left fossa, that can also mislead you. The patient may have acute appendicitis. For that, the urine routine microscopic examination need. If there is infection there is a pus cell is there. Sometimes there is RBC is there. So that RBC always associated with infection, or sometimes the inflamed appendix. Whenever the ureter is inflamed, by the inflammation is touches from the appendix, the ureter is inflamed. That may causing some RBC in the urine. But in that cases, pus cell may not present there. But in case of RBC, if there is a stone in the ureter, that ureter causing pain, ureter stone passes the ureter and causing some hemorrhage, some RBC in the urine. So in case of female, always that RBC may not be the disease of the ureter or the other, it may be a menstrual blood. So for that reason, in case of female, you must take the history of menstruations. Otherwise, that urine examination having some RBC is there, which can dictate that the patient having RBC, that means some urinary disease there. What about the other investigations? The other investigations, selective one, are here. In case of female, if there is any menstrual period, there is a menstrual period gap there, so in that case, you go for the urine for pregnancy test. There may be pregnancy there, early pregnancy. And in case of urea and electrolytes, selective, that means whenever the patient is more infection and they are in that, or diarrhea there, in that case, you go for the electrolyte and renal function must be evaluated. And for routinely, go for the supine abdominal radiograph. That radiograph, that is written in the new edition of the Belgian lab book. Previously, we can teach the student that plain X-ray QB region. So it is more specific one, supine abdominal radiograph. Because in case of plain X-ray QB region, the X-ray done by a lying person. These are the same nomenclature. Only the terminology are different. Supine abdominal radiograph. But normal abdominal radiograph are taken by in erect posture. But here written is the supine abdominal radiograph. Why the term is written there, supine abdominal radiograph? I don't see any books why the choice is there, supine abdominal radiograph. But from my experience, the explanations are, if you do an X-ray in an erect posture, abdominal X-ray, suppose the patient having a ficoli there. If the appendix is hanging down, so it is not in the anatomical position. It can mislead you, that ficolis shadow mislead you with the ureteric shadow, ureteric stone shadow. It is one of the cause. Another thing is, we do the operation in a lying posture. So if you do an X-ray in a supine position, so during operation, the anatomical location is more accurate than an erect posture X-ray. If you do an X-ray in an erect posture and do an X-ray in a lying posture, in a lying posture and erect posture, the difference is the stone or the ficoli, it may shift 1 or 2 centimeters below medial or lateral due to the gravitational or visceral position movement of the body. For that reason, probably they in the new edition book written is supine abdominal radiograph. But for your undergraduate student, the old conception, you can give the answer. Plain X-ray QB region. It's better. And another one is ultrasonography. So ultrasound of the abdomen and the pelvis. That means whole abdomen ultrasonography must be needed. Not only the ureter, not only the uterus, not only the kidney. Whole abdomen ultrasonography always give, always, and evaluate particular attention to the right lower abdomen. So what are the findings you can find in case of ultrasonography? That ultrasonography can help you and can dictate you or can confirm your diagnosis to some extent, sometimes more confirmatory. Because whenever do an ultrasonography, they can give the information, those structure which lies on the right side of the abdomen, lower abdomen, and in the pelvic cavity. So right side of the lower abdomen, what are the structure lies? By doing ultrasonography, we can evaluate the ureter, kidney, bladder. So urinary system you can exclude. There is no hydroureter, no hydronephrosis, no visualized stone there. So by that thing you can exclude the patient does not having a uretary colic. Then in case of female, they can evaluate the patient does not having any fibroid uterus, or the patient does not having a fallopian, that means ectopic pregnancy, or does not having a ovarian tumor, or does not having an ovarian cyst. That can give information by doing ultrasonography of the pelvic cavity. And another thing is, if the sonologists are expert enough, and your ultrasonography machine is high resolution machine, so in the end, if the sonologist give the time for examination, in that cases, most of the cases they can diagnose that there is a distended appendix lumen, there is a base, there is a fecolic there, they can give the information by doing an ultrasonography. But that ultrasonography must be done by an expert, sincere sonologist. Otherwise, most of the time they can miss it. For that reason, it is we are not always believe the sonography report, because most of the sonologists are not expert enough to give the information that it is not appendicitis. No. If somebody say there is a distended luminal tubular structure in there with a fecolic, you say most likely the patient diagnosis is confirmed. And another confirmatory is direct visualization by looking at picture. It is called a contrast enhanced CT scan. If you contrast enhanced CT scan, reconstruct the picture and cut in a coronal, sagittal, all sections, you can evaluate the lumen of the appendix, you can evaluate the length of the appendix, you can evaluate the wall of the appendix, if you can evaluate there is a lump formation or not. With all the things you can assess by doing and contrast enhanced CT scan with the expense of money. Big amount of money is required for investigation, which is not possible in our country in all the individual to do the CT scan. So for your exam, your basic question answer investigation is, first one is plain X-ray, blood for complete blood count. Blood for CBC, complete blood count, one. Second investigation is urine for routine and microscopic examination. Third investigation is plain X-ray cube region. Fourth investigation is ultrasonography of whole abdomen, particular attention to the right lower abdomen. These investigations can diagnose most of the case of the appendicitis, except in the rare variety in our context. But in an advanced country, they are routinely go for the contrast enhanced CT scan. So CT scan can also more or less confirmatory that the patient having appendicitis or not. There is some scoring system discovered for the diagnosis of appendicitis. So these are Alvarado scoring system. For the easy remember, the term is Mentrels. That means M, the symptom from the symptoms, M for migratory right iliac fossa pain, A for anorexia, N for nausea and vomiting. So these are from the symptoms. You can take the points and give the marks 1, 1, 1. Is the patient having only nausea and vomiting 1? Migratory pain 2. So if there is a no anorexia, so the scoring that from the area is 2. So by that by in that manner you can easily scoring the system of scoring. So from the symptom that MAN, migratory right iliac fossa pain, A for anorexia, nausea and vomiting. From the signs, the other points are tenderness, right iliac fossa tender, rebound tenderness, that means from opposite side of pressure, and elevated temperature. That also give the score is 4. The others are laboratory. L for leukocytosis, L for total count is raised. Leukocytosis, 2 mark, scoring 2. And shift to the left. It is a very beautiful terminology, shift to the left. It is a phrase. That means that leukocytosis representations is that due to the increased neutrophil count, so the total count is increased, so it is leukocytosis. So whenever the more production of leukocyte neutrophil needed, so in that cases, emergency need to supply. For that reason, there is no time to mature the neutrophil. So segmented immature neutrophil go into the circulation, which is represented in the blood picture showing under the microscope. That terminology is called the shift to the right, shift to the left. Shift to the left. That means immature neutrophil when seen in the blood picture slide, then your diagnosis that the patient most likely having an acute infection there, needed more supply, so the more production of neutrophil comes into circulation. Then it is called the score is 1. So that total score is 10. So not whole 10 marks scoring in all the patients. So that interpretations are, if the score is less than 5, then the diagnosis is not sure. It may be not sure. But if the score is 7 or more, it is strongly predictive of acute appendicitis. Strongly predictive. When the score is 7 or more, strongly predictive. In patients with an equivocal score, 5 or 6, abdominal ultrasonography CCT is used to further reduce the rate of negative appendicectomy. So whenever the score is 7 or more, in that cases you can go for less investigation like CT scan. But whenever there is a confusion, 5 or 6 scoring system, then you can more confirmation for more negativity of the appendicectomy, then go for CT scan, ultrasonography, etc. What about the complication? If you don't treat the patient, if you don't come to the patient at the right time, and take time in home without treatment, lately present to you, so there is some complications. So the complications are appendicular lump formation. Initially there is infection, so the protection of the body, all the visceral surroundings go together and make adhesion there, more supply there, wash the infection. But if it is possible to resolve, then the lump disformation ultimately is resolved. If the lump is not resolved, the infection is more severe, so in that case the patient develops appendicular abscess formation. Sometimes the appendix becomes gangrenous, so gangrenous appendicitis. That gangrenous part of the appendix may become perforated first. Then perforation causing swelled up pus in whole of the peritoneal cavity, which causing peritonitis. That infection, whenever go into circulation and go into the bacteremia, septicemia. So whenever the infection is migrated through the portal vein, from the iliac fossa, through the portal vein, go to the liver, portal pyemia, and that portal pyemia localized to settle in the liver and form the abscess, which is the liver abscess. Or sometimes the appendicitis become resolved, and after a few days or few months or few weeks to few months later, again there is a pain, the patient present with the recurrent appendicitis, or the patient present to you with a pelvic abscess. So these are the complications of acute appendicitis. if you don't treat. If you treat earlier, you can avoid that lot of complications. So treatment. Treatment is only one, which is surgery. You remove the appendix because it is a organ which is not in the central line of the GI tract. It is a one-sided wall extended part. So it does not essential for the body. So in case of acute appendicitis, you must remove it out. So whenever you go for treatment, always nowadays, the surgical treatment again divided into two types. One is conventional, that is open surgery, and another one is minimally invasive surgery, which is called the laparoscopic surgery. So one is conventional appendicectomy, another one is laparoscopic appendicectomy. So look at the picture. The dotted line is represented the incision needed for open surgery. So this is a big incision is needed there. And there is only the tiny holes, 3 holes can do the surgery. It is a minimal invasive surgery. So it is more cosmetic value, less pain, early recovery, early discharge, early join to the job, and early earning money. But here, it takes time to heal. It is more pain, so the scar is more, less cosmetic value. So these are the appendicitis, appendicectomy methods. One is conventional, another one is laparoscopy one. So for your level, undergraduate level, must know the name of the incision doing for appendicectomy, because there is some operative surgery questions in the exam. So for that reason, the terminology must be known. The incisions made during open appendicectomy are not all the incision made, only one incision is made for the surgery, but that incisions are given upon the what is the presentations and what about the severity. According to the severity, the incision is made. If it is a very less pain, less distension, less toxic of the patient, in that case, you can most likely small incision, you can easily identify it and remove it out. So in that cases, we choose the large incision. But first utter the name of the gridiron incision. So another one is Rutherford Morrison incision. Another one is Lanz incision. Another one is right lower pyramidal incisions. Another one is lower midline incision. So one by one, it is a gridiron incision. So the gridiron incision, that incision is given where? At the McManus point. So at the McManus point, so that McManus point you first identify. That means you draw a spine umbilical line from anterior spine to the umbilicus, draw a line, then middle third and lateral junction. If you right angle to the line, if you make an incision, it is called the gridiron incision. Because, so first you make an incision, skin and subcutaneous tissue, cut it there. So after cutting the skin and subcutaneous tissue, then you look, there is a white external oblique appendices and to some extent muscles above. So that is again divided in the same line. So skin, subcutaneous tissue, external oblique appendices are divided in the same line. After that, you look, the muscle of the internal oblique and transverse abdominis, the direction of the internal oblique is like that way. The external oblique is towards the pocket. The internal oblique is opposite to it. And transverse abdominis is like that transversely. So other two muscles inside the external oblique appendices are internal oblique and transverse abdominis that are splitted by opposite directions. In the same, after exposing the external oblique muscles, they retract with the lens retractor. Look inside, there is the internal oblique muscles. Then look inside is the transverse abdominis. So both the muscles are split with the mosquito forceps or medial artery forceps, and that is splitting done in the opposite direction. so that it looks like a grid iron. For that reason, the name of the incision is grid iron incision. And after that, whenever you retract all the muscles with the retractor, then you look, there is a first number cell is extraperitoneal fat peritoneum. Look there. That lift up the first number cell is extraperitoneal fat peritoneum with the two mosquito forceps. Lift it up and examine the two finger pinch between the mosquito forceps. Is there any other structures there? If any confusion, then you can detach the mosquito, again lift it up, then you confirm it, then you incise the peritoneum with the belly of the knife. So after that, the peritoneum is open. So introduce the lens retractor, retract the muscles and the parietal peritoneum, then look inside, the abdominal cavity is there, open up. And after that, if the appendix is easily can identify there, then you can lift it up with the back of forceps. If it is not visualized directly, in that cases, you can place your finger, index finger, inside the abdominal cavity and palpate, ascertain, is there any tubular structures felt by your finger. Then you proceed further. And if any confusion, then you lift up the cecum, pull it out with the back of forceps and look the tinea, go at the base, then you can identify the base of the appendix. Hold up with the back of forceps, lift it up, then hold the appendix, pull out and go for appendicectomy by dividing the mesoappendix with the appendicular artery first, then you ligate the base and divide it with a knife, wash the stump and send the specimen to the trolley and base of the appendix again placed in the abdominal cavity. And after that, you ensure there is no bleeding. Then you close the peritoneum, first number cell is extraperitoneal first, then internal oblique transverse in the second layer, the third layer is with the external oblique abnormalities, and lastly, skin and subcutaneous tissue in a single layer, either subcuticular or interrupted stitches. So this is about the open appendicectomy method. So this is about the grid iron incision. But in case of Rutherford-Morrison incision, the name is here. Whenever the grid iron incision do and look, the appendix is not visualized, it is not possible to expose. In that case, more exposure is needed. So then you make an incision over there. So that incision is extended and cut the internal oblique and transverse muscles and put the retractor inside and retract. So that incision, whenever extended, cut the muscles, more exposure is there, the incision is needed to extend, which is represented on the left side. It is not the left side, on the right side for easy visualization. That incision, whenever is there, it is called the Rutherford-Morrison incision. Rutherford-Morrison muscle cutting incision. It is sometimes needed in case of open appendicectomy. Difficult whenever the appendix is high up or very severely infected and inflamed there, in that cases. So it is Rutherford-Morrison muscle cutting incision. You cut the internal oblique transverse muscles. For that reasons, the name of the incision is Rutherford-Morrison muscle cutting incision. It is not in all cases. It is a very difficult cases sometimes done. What about the lens incision? But nowadays, most of the surgeons nowadays, except few, they are doing with the lens. That means whenever do a grid iron incision, the skin is more vertical. So it is not matched with the crease line because the abdominal crease lines are transversely lies. So if you do a transverse incision there, so in that cases the incision is matched with the crease, so more cosmetic value. For that reason, they are most likely they do it the lens incision. This is the same incision the grid iron incision, except one, the incision is a vertical. It is given or made at the McBurney's point in a horizontal manner, transverse incision. So transverse incision at the McBurney's point is called the lens incision. and other muscle incision are same. Only the incision is transverse. So what difficulties or the difference between the lens and gridiron? The only difference is only the skin incision is transverse instead of right angle to the spine umbilical line. And there is difficulties is in case of lens incision, it is to some extent more difficult to expose the side. It is only one difficulties. So in case of gridiron, the exposure is better. In case of lens incision, the exposure is less amount. So it is difficult to handle. If it is a difficult, in case of lens incision, it is more difficult to gridiron. But it is more cosmetic value. For that reason, we are mostly practice the lens incision. But for your exam, your answer is, for your level, is gridiron incision. Be careful about it. For undergraduate level, your answer is gridiron incision. The other two incision is right paramedian incision, lower median incision. There is a right paramedian, there is a lower median incision. So that two incision are reserved for the patient, those having a diagnostic confusion, or there is a big lump there which is not resolved, or there is a big abscess there, or you can suspect the other pathology with. In that cases, you go for the lower midline or right paramedian incision. That two incision, any one of them is given only on that cases. So these are about the operative surgery of the open appendicitis. So look at the picture. After exposing the appendix, mesoappendix, cecum in the exterior, then you make a window in the mesoappendix, hold by two forceps, mosquito forceps, then divide it. Then the vessels are secured with the becquerel, and after that, the appendix is floating. So you need to divide the appendix from the cecum. So at the base, you make a tie, and proximally you put a artery forceps. Then you divide in between the tie and the forceps. So then the appendix is sent to the trolley, and this is called the Babcock forceps. There is a special caliber at the end. There is a fenestrations, so it can easily hold the appendix and easily catch. For that reason, the name of the instrument, sometime asked in the exam, the name of the instrument which catches the appendix is called the Babcock forceps. So whenever is a appendix stump is healthy, in that case is only the tie is sufficient. But whenever the appendix base is gangrenous or almost perforated there, in that case it is not possible to make a tie like that. In that cases, the appendix stump is closed like a jet type of incision, suture, tie. Make a stitches from here to there, then go there, again go there, and then make a tie. So the appendix stump is occluded by the jet stitches. Or sometimes they can continuously surroundings the base of the appendix, continuously take the tie and make the tie. It is called the bursting suture. These are two for reserve when the appendix base become unhealthy, only on that case. So another most favorite terminology and the procedure is the laparoscopic appendicectomy. Nowadays it is more favorite than open appendicectomy. The cause is it is more cosmetic, less pain, early recovery, early go to home for their cases. So the approaches of laparoscopic appendicectomy, the pneumoperitoneum and other steps are same, just like a laparoscopic cholecystectomy. The first port is the same. You make a first port at the umbilicus, which is called the telescopic port, that is camera port, through which the camera is introduced and look inside the abdominal cavity. The other two ports is required. One port for required to lift the appendix, other port is required to cut the tissues, bond the tissues, ligate the tissues. So the other two is called the working ports. So in case of appendicectomy, there is a three ports is required, one for telescope, the other two port for working port, ligation, division, etc. So the working ports are one in the suprapubic region, another one is the left iliac fossa, and somebody may, without left, they go for the right iliac fossa. So any of the three position they can do, it depends upon the surgeon's choice. It is not the mandatory all the time, the port on the left side, not all the time to require not the left or the right, but it depends upon the surgeon's choice. So only 3 ports can sufficient to do the appendicectomy. So be careful about it. In case of laparoscopic cholecystectomy, there is 4 ports. One in the epigastrium, another in the hypochondrium, another in the right iliac fossa. These 3, 4. But in case of appendicectomy, there is a 3. So the position of the appendix, the port position is not always in the fixed one. It depends upon the surgeon expertise, personal surgeon choice. Sometimes a patient having a appendicitis along with pregnancy. If along with pregnancy, in that case the uterus lies in the pelvic cavity. So you must avoid the 2 port there, because if you make a port there, there is a chance of injury to the uterus. In that case, you go the port epigastrium, umbilicus, or supraumbilical, or in the right hypochondrium. That 3 port can do the appendicectomy. So the position of the ports are not mandatory fixed. Usually on the right side or left side, the iliac fossa and supraumbilical and suprapubic region. But your answer is 3 port is required. It is sufficient. One umbilicus, and other 2, one is suprapubic, and another one is either right or left iliac fossa. This is sufficient. So what about the post-operative complications? So appendix is a dirty thing. It is a continuation of the fecal content organ. So whenever you cut the appendix, so there is chance of contamination of the wound, particularly in case of open appendicectomy, because you pull the cecum through the wound, through the muscle cut, and go to the exterior. So there is every possibility to contamination of the open wound during open appendicectomy. So wound infection, it is an important early complications. Treatment is wound drainage. If there is infection, you must drain the collections and under antibiotic coverage. Or you do the surgery, but the infection is so severe that there is a lot of pus inside the abdominal cavity, particularly in the open appendicectomy, don't able to suck all the content from the pelvic cavity, from the right iliac fossa, or underside the diaphragm. So there is chance of intra-abdominal abscess in case of conventional appendicectomy. Sometimes the infection post-operative period during surgery, you handle more the ileum, intestine, etc. So there is more chance of ileus. In some advanced country, not in our country, we are not prone to develop deep vein thrombosis. But in advanced country, they are more prone to develop any source of surgery. There is chance of development of deep vein thrombosis. So venous thrombosis and embolism in elderly and women patients, those having the oral contraceptive pill, more prone to develop, which is more in advanced country, not in our country. And another thing is if the appendix is too much infection there, so before doing the surgery, there is already the patient having a portal pyemia. That pyemia causing the portal pyemia, and ultimately the patient may having a liver abscess. And if the surgeon is not skilled enough, he can hold the cecum, lift it up, causing injury to the cecum, or the base is not secured properly. Subsequently, the patient may present it as a fecal fistula. It is one of the complications. And lately, the patient may present to you is the adhesive intestinal obstruction. That means you do the surgery in the right iliac fossa, in the open surgery, particularly in the open surgery, there is more chance to develop adhesion because you handle the intestine and guards forcefully, blindly, don't able to look very precisely inside lumen. So there is more handling there. So whenever there is more handling, more injury, more trauma, so there is more chance of post-operative adhesions. For that reason, in case of open appendicectomy, there is chance of adhesive intestinal obstructions. Late complications may develop. Another important thing is the right inguinal hernia. But in case of postgraduate surgery examination, that question must be asked in the exam. After doing appendicectomy, why the patient developed right inguinal hernia? Because during appendicectomy, they don't touch the deep ring, they don't touch the inguinal canal. So why the inguinal hernia is developed? The answer is during appendicectomy, open appendicectomy, they divide the external oblique muscles, interoblique muscles, and transverse muscles. So during dissection of the muscles, they injure the ilioinguinal nerve. So that ilioinguinal nerve supply the lower part of the abdominal wall. So if the lower part of the abdomen become weak, so during sneezing, coughing, etc., maturation, defecation, the lower muscle is not contract properly. If the lower muscle does not contract properly, so there is a chance of direct inguinal hernia. So the explanation is injury during appendicectomy. If it injure the ilioinguinal nerve, there is a chance of development of inguinal hernia. So be careful, memorize that why the hernia develops, because right inguinal hernia develops after appendicectomy. This is the answer. So look the picture of laparoscopy appendicectomy. So how precisely the surgery done without touching the other viscera? So look, the appendix is distended. The base is mesodermally divided, the base is ligated with extracorporeal knot with the big sutures. Then divided, the appendix put in a retractable bag, because if you pull it out to a normal port without bag, so there is chance of port infection more. So for the prevention of the port infection, put within a retractable bag and pull it out through the port, so there is no contamination of the dirty appendix with the port, so there is less chance of infection. So this is the surgical technique to minimize the infection in post-operative period. It is more precisely done in laparoscopy 1. So look, the appendicular lump formation. So how the lump is formed? So the lump is formed by sharing all the viscera surrounding the appendix. It is the answer. So what are the viscera surrounding it? So look, it is the localization of infection occurring 3 to 5 days after attack of acute appendicitis. It is formed by inflamed appendix, greater omentum, edematous cecum, parietal peritoneum, dilated terminal ileum, and others which is not written here, which may be a take part of the sigmoid colon, in case of female, fallopian tube, ovary, etc. So how we diagnose appendicitis, a particular lump? That means the lump located in the right iliac fossa. So there is a tenderness, but the lump is tender and smooth surface, firm in consistency. And you can easily delineate the outline of the lump, well localized, found in the right iliac fossa. So there is a previous history of pain followed by lump formation in the right lower abdomen, which can be delineated by examination that tender, smooth, firm, well localized found lump, which is most likely diagnosed is appendicular lump. Management. So management is initial conservative treatment if the patient's condition is satisfactory. That means if the patient is not more toxic, in that case, satisfactory. You can conservatively treat the patient, and subsequently the lump is resolved when the infection is subsided by more supply there, the adhesion become detached, the appendix become free. So with that aim, the Ostner-Schirren regime is done. That Ostner-Schirren regime sometimes in the short note in the exam, sometimes asked in the viva, sometimes written in the OSPI. So look, initially conservative treatment if the patient's condition is satisfactory. The regime is Ostner-Schirren regimen. Complete bed rest, temperature, blood pressure, pulse chart maintained, nil by mouth until further order given, IV fluid to maintain the fluid balance, broad-spectrum antibiotic, ampicillin, metronidazole, gentamicin, analgesic according to the severity of the pain, initial nasogastric aspirations, identification of the progression or regression of the lump. Then I follow up the patient and I note it, what is the size of the lump and what is the size of the lump. On the next day, is there any change of the lump, etc. Patient is discharged and advised to come for interval appendicectomy after 6 weeks. When the regression of the lump, then discharge the patient and go for interval appendicectomy for 6 weeks, because there is after 6 weeks, because there is chance of recurrent appendicitis. So once the lump is formed, there is a chance of lump formation or other complication metabolic. For that reasons, we routinely advise the patient go home and again after 6 weeks go for surgery. Why elapse the time of 6 weeks? Because that 6 weeks time to spontaneously resolve the inflammation. So when the inflammation is resolved, there is a free of the appendix, do the surgery most easily. Conservative management is given initially because inadvertent surgery at this time is difficult, bloody and dangerous. Because if the patient earlier to the lump formation come to you, if you do the surgery, very easily can do it because there is filmy adhesion. But when it takes time, 7 to 8 to 10 days, the filmy adhesion become more harder. In that case, it's difficult to manipulation and there is more chance of infection, injury to the surrounding viscera. So for that reason, conservative management is given initially because inadvertent injury at this time is difficult and bloody and dangerous. It made difficult to find the appendix and occasionally fecal fistula may form. Criteria for stopping the conservative treatment. When you stop the conservative treatment, the obstruction regime, when stop? When the pulse rate is rise, increasing or spreading abdominal pain, increasing the size of the mass. So whenever the pulse is raised, that means the patient having more inflammation, they are more pain, they are tachycardia, they are it representation, the deterioration of the condition. And increase the size indicates it is not resolving, it is deteriorating. Then you stop the regime, go for surgery immediately. But contraindication of conservative management, when there is a diagnosis in doubt, you don't confuse. Whenever confusion, you don't go for conservative treatment. When the patient is under the age of 10 years, because at that time there is poor development of the tetramentum, early perforation of the appendix, and when the patient is over the age of 65 years, there is a bias towards the immediate operation because of the frequency of peritonitis with minimal clinical signs in these age groups. What about the appendicular abscess? When the appendicular mass is not resolved, or the patient presents to you lately without any receiving the treatment, then the patient presented with appendicular abscess. So that appendicular abscess occurs. Why? Due to suppuration in an acute appendicitis or suppuration in an already formed appendicular mass. Failure of resolution of appendicular mass or continued spiking pyrexia usually indicates that there is a pus within the phlegmons appendix mass. It is very important thing is continued spiking pyrexia. That is the main features of appendicular abscess formation in the lump. So the clinical features is high fever, tender, smooth, soft, swelling in the right levels. When the abscess formation, that means the abscess become ripened. There is the pus is more, for that is more soft in consistency. But it is tender and there is a systemic temperature, it is high fever. And show the picture. It is very important picture here because sometimes ask in the exam, what is the treatment of appendicular abscess? Most of the students give the answer that extraperitoneal drainage. It is a wrong answer because extraperitoneal drainage is not possible all the time. If you know carefully the anatomical position of appendix, so the anatomical position of appendix dictate the formation of appendicular abscess, where the location of the abscess is. If suppose here, if the position of the appendix is retrocecum, so in that cases, the cecum is pushed forward, the abscess is formation behind the cecum. So only in that cases you can possible to make an incision over the skin and muscles. You don't need to open the peritoneum. You can incise the skin, subcutaneous tissue, muscles, then you open the abscess cavity, directly pass it in. So without communicate the peritoneal cavity. In that cases, you can possible to do the extraperitoneal drainage. But in case of pre-ileal or post-ileal appendix position, if the abscess is formed, you don't possible to go for open extraperitoneal. Always the drainage must be needed through the intraperitoneal approach. Be careful about it. If your conception is clear, you can easily understand. That means if the appendix is the pre-ileal or is the post-ileal variety, the appendix abscess is formed here. So it is not possible to drain extraperitoneal. In that case, the drain must be through the transperitoneal. That means transabdominal go and drain the pus. But in case of pelvic appendicitis, in that cases, it is usually don't practice with the transperitoneally. We can drain it through a natural process. That means either in the rectum or in the vagina, transrectal or transvaginal drainage. So the pus is expelled out there through the natural orifices. The patient can symptom-free, and after, in case of abscess, always do the appendicectomy after 3 months. But in case of lump, the appendicectomy is done after 6 weeks. It is a basic difference. But in case of abscess, there is more infection, more inflammation, more dense adhesion there, more phlegmon formation there. So it takes time to resolve the surrounding adhesions. For that cases, you can do the appendicectomy after 3 months. But in case of appendicular abscess drainage, if the patient is lucky enough, if the surgeon is lucky enough, in that cases, he can do the appendicectomy same sitting if the appendix is hanging within the abscess compartment. Only that cases, you can do the surgery appendicectomy simultaneously with the drainage of the abscess same sitting. But if the patient is unlucky, if the surgeon is unlucky, then there is a chance of second surgery needed subsequent. So this is the management. If appendicular abscess is diagnosed, then drainage of the abscess is the treatment of choice. In case of retrocecal appendix abscess, open extraperitoneally, incision is made at the center of the swelling, nearer the lateral aspects. Skin external oblique is incised. Deep muscles are divided rather than divided to give freer exit to the contents of the abscess. Then enter in the abscess cavity and drain the pus. Then put a drain there and close the wound subsequently. In case of subsequent abscess, can be opened in the same manner because it is very nearer to the lateral wall for that disease. The incision being made nearer to the anterocerebral axis, more down. But in case of pre-ileal and post-ileal variety, can be reached only through the peritoneal cavity. Very important one. In case of pelvic abscess is drained through the rectum or the vagina. Percutaneous drainage of an appendix abscess under fluoroscopic or ultrasonographic guidance by a skilled interventional radiologist. This is preferred treatment for many cases, which is not feasible in our context because our facilities are not so available there and expertise is not there. Go for the percutaneous drainage there. So percutaneous drainage is another option there. So you can sonoguided, you can drain the pus, put a catheter and resolve the abscess, then subsequently go for the appendicectomy later on. So recurrent appendicitis, characterized by recurrent episodes of lower abdominal pain, incomplete obstructions, intensity vary, occur every few months. An appendix is thickened and fibrous. So look the appendicular lump formation, how treated by a laparoscopy, that operation done by me. So it is not for your exam. Never ever say in the exam appendicular lump treatment is immediate operation. No, your answer is first conservative, then go for surgery. But if the surgeon is expert enough, then that can go for surgery and facilities available there. So appendicular abscess, look how the pus escape out. So suck the pus, then the appendicitis defined, remove it out. What about the neoplasm of the appendix? So two types of malignancy occurs in the Vermiform appendix. One is carcinoid tumor, another one is adenocarcinoma. So among them, carcinoid tumor is the commonest one. Carcinoid tumor, another name is argentinoma. That carcinoid tumors arise in argentinine tissue, Kulkiski cells of crypts of lubricant. Its incidence is 1 in every 300 to 400 appendices. site any part but frequently found in the distal third of the appendix. So look, it is important information is the carcinoid tumor arises in the distal third of the appendix, body and tip, and features similar to acute appendicitis. Presentation similar to acute appendicitis. So the treatment is, if it is a distal part, then the treatment is very simple, go for appendicectomy. But if the carcinoid tumor or the adenocarcinoma is developed, carcinoid tumor is developed at the base of the appendix, so it is touches the cecum. So in that case, a more extensive resection is needed. Go for the right hemicolectomy. So the treatment plan is, if tumor size is more than 2 centimeter, if it is 2 centimeter more, in that go for right hemicolectomy, and lymph nodes are involved, go for right hemicolectomy. Or if the tumor is smaller size but at the base of the appendix, you can go for the right hemicolectomy. So the chosen treatment is two. One is appendicectomy or right hemicolectomy. The right hemicolectomy included the appendix also. For that reason, in the right hemicolectomy not written there, appendicectomy. So appendicectomy also removed, appendix also removed along the specimen of the cecum. For that reason, the name of the operation is not appendicectomy. Whenever go for the right hemicolectomy, your answer is right hemicolectomy. But only whenever you only remove the appendix, the treatment option is appendicectomy. So if it is less than 2 centimeter, if it is in the tip, you can appendicectomy is sufficient. But if it is more than 2 centimeter or 2, you can go for right hemicolectomy. If the lesion is 1 centimeter, but there is a multiple lymph node there, you don't go for appendicectomy, you go for right hemicolectomy. Because in case of right hemicolectomy, you remove the terminal ileum, cecum, appendix, ascending colon, right 1/3 of the transverse colon, and along with the mesentery of the surrounding is the ascending colon and cecum and terminal ileum. So all the lymph nodes are en bloc excision. So wide excision, they are more clearance of the malignant tissues. There is a more curative treatment done. For that reason, the answer is right hemicolectomy. So thank you everybody for patient sharing, and thank you for all the ins and outs of appendix. Though the appendix is a very smaller organ, but the knowledge needed is vast. Otherwise, you don't able to understand the question, you don't able to understand the rightly, properly give the answer in the written or in the viva or other OSPX, etc. So now the session is open for question and answer session. Do you have any question, any query? Ask now. Any question?
Sir.
Aslam?
Sir, what can we do with a silent appendix? How we can we ever diagnose a silent appendix?
There is this silent appendix. I don't know is there any terminology of silent appendix. Whenever the appendix is not any symptom, normal one, it could be a silent one. So what is the meaning of silent appendix? I don't know about it. But one thing is missing in my lecture is, what is the appendix is needed for other reconstructive surgery? The answer is yes. Suppose a patient having a ureteric injury, there is segment of the ureter is lost. So in that cases, that ureter is divided from the base and tip is cut. So it acts as a tube, but the vessel is maintaining, mesoappendix is attached there, and that appendix is interposed at the segment loss of the ureter. So that organ is transplanted from here to there for continuity of the ureter. It is possible to do it. For that, it is one of the most important organ is in the body for substitutes the ureter to some extent of the injury whenever it is lost there. Or in case of continent urinary diversion, if the ileum is divided, ileum and ascending colon is attached, so the ureter is transplanted in the ileum and the cecum reservoir, and if that appendix tip is cut and attached to the umbilicus and make an opening there, by the put a catheter there, you can urine collected from the cecum to the exterior. So it acts as a diversion, external easily communication for the formation of diversion. That appendix also take a part. So it is a very important function for organ substitutions of the body. So any more questions? The appendix is so common and everybody read. Various times there is revision occur. So for that reason there is a question is less. But so good luck for you. Our next discussion day after tomorrow, we can discuss with the esophageal diseases. So esophagus is neglected by the surgeons because it is a very proximal organ, less disease occur, but esophagus is a very interesting organ. We want to need to read the esophagus and its diseases on the day after tomorrow at 10 p.m. So thank you very everybody. Thank you for sharing.
Thank you, sir.
Thank you, sir.